A very good afternoon to you all. You're very welcome here. I'm just going to give people 1 or 2 minutes to log in, and then we'll start this afternoon's masterclass. It's great to see so many of you here, and there's a kind of digital rush going on as people join, so we're just going to give people a moment to do that. Okay, I think we'll start anyway as people join, just with the preamble. So it's, as I say, it's a great pleasure to welcome you here to the Value-Based Health and Care Academy in Swansea University in Wales. A warm welcome to everyone, particularly those who are joining us from overseas. This is the first of our masterclass series in value-based healthcare, and we're really excited to be launching the series today. And we plan to run a series of masterclasses throughout each year for the foreseeable future, and we'll be picking topics that we think are challenging, pertinent, timely, and will be of interest to those of you who are looking to implement value-based health and care, or just interested in finding more about it. My name is Hamish Lane. I'm the director of the Value-Based Health and Care Academy here in Swansea, and I am a professor here in the School of Management, the business school in Swansea. We're very fortunate to have 2 excellent leading speakers to stimulate our thinking during the masterclass. And the way it's going to run is that we're going to start with Dr. Sally Lewis in a moment. Sally is, well, I'll introduce Sally in a moment, but she's going to set the scene. And then she's going to be followed by Gérard Klop. And there will then be an opportunity for a question and answer session. We very much hope that you will engage actively in that. The whole purpose of this masterclass is to really get to the heart of the subject matter. And then we'll close for 2 o'clock British Summer Time. So the masterclass will last an hour, including the question and answer session. It is being recorded, and we will be posting it on our webpage probably next week, so that you can watch it back, or if you have colleagues who missed it, they can come and watch it too. So please do pose questions using the Q&A, not the chat, but the Q&A function of the webinar during while people are speaking, or when we get to the Q&A itself. And as you will see, there is an opportunity to upvote a question by saying that you like it, and that will prioritize it in the question taking, and we'll be using that as a way of structuring the Q&A. So if you see someone else's question and you like it, please do click on like, and that will help to move it up the priority order. And if for any reason your connection fails, please rejoin using the same link that you've used now. We are having a slight technical difficulty with Sally's video camera, unfortunately. So at the moment, it isn't possible to see her, but you will be able to hear her and see her slides. And so I'm going to hand over to Sally, who is the National Clinical Lead for Value-Based Healthcare and Prudent Healthcare here in Wales. So Sally, thank you very much.
Thank you, Hamish, and I hope you can all hear me. And I've spared you the pleasure of seeing my face today, but I might pop up from time to time. My camera is being a little bit intermittent, so apologies for that. So how can we use value-based healthcare approaches to start to recover healthcare services as we emerge from the pandemic? And I want to particularly focus, of course, on older people's care today. And as we know, value-based healthcare is fundamentally about understanding our outcomes, understanding the outcomes that matter to people, and in this case, older people, and then working out how we can deliver the outcomes that matter to people with the resources that we have. And as you will appreciate, we're all facing very major challenges now as we move out of this pandemic to start to improve the outcomes of people with non-COVID issues who may have been seriously impacted upon indirectly by the pandemic. So hopefully I can move my slides along. So what's happened? This is the virus, of course. And at the beginning of the pandemic in March 2020, we saw a single massive effort from healthcare systems against this virus. And that was very effective. We worked very effectively, certainly in the National Health Service in Wales, in pulling together around mobilising public health and the healthcare system around issues of infection control and, you know, how we might treat people with this new pathogen that we knew so little about. But we also saw the impact of lockdowns, of quarantines and other public health measures, which meant that as well as avoiding their usual activities of daily life, people may have avoided accessing healthcare, and that may have did have an impact on their ability to manage their chronic disease, for example, and also to seek help for acute healthcare problems because of fear of contracting the infection when they accessed healthcare, and also because access was limited by virtue of the fact that we were trying not to congregate in spaces together. And we really did see a huge change in the way services were accessed. So, for example, in primary care in the UK, all access to see a general practitioner was done through total triage, so either through an e-consultation or on the telephone. And of course, as we move out of the pandemic, we're very much focusing on preventing non-COVID harm as well, and seeing what's happened to people who may have had cardiovascular issues or developed a new cancer or had their cancer treatment interrupted in some way, by way of example. So where are we now? Well, we're in a true VUCA environment. So VUCA is a concept often used by the military, and it stands for volatile, uncertain, complex, and ambiguous. And I would argue that we've never been in a more true VUCA environment, a real perfect storm for healthcare services of, you know, trying to cater for multiple needs who are, you know, competing for resources, particularly in publicly funded healthcare systems. And we see a plethora of gold standard guidance coming from professional bodies around the gold standard way to manage patients with differing needs. And, you know, can we meet all of those needs? How do we prioritize as we move through and out of this pandemic? And as there is competition for resources, particularly in publicly funded healthcare systems, there's of course potential for inequity of access to healthcare services, either because of geography, but also between patient groups and people with differing needs. And even in countries where there is not a publicly funded healthcare system, it's an insurance-based payer system, we see inequities coming in other ways, of course, depending on ability to pay. So as we start to prioritize our way out of the pandemic, we need to really focus on those time-sensitive interventions that are going to have a serious impact on patients if we don't attend to them right away. And that will mean that some other individuals who have less pressing need may need to wait a little bit longer. And that's a difficult conversation that we have to have with the public, but I think a necessary one if we're going to really equitably improve outcomes as we emerge from the pandemic. There are interdependencies in all healthcare pathways, of course. So it's all very well having access to a general practitioner or access to an MRI scan or a CT scan. But if the patient can't move on to the next stage and get their treatment in a timely fashion, then that just creates a bottleneck and doesn't improve things. So we need to take account of those interdependencies and multiple demands on key parts of the system that many specialties require, such as imaging or ICU utilization. And while we're trying to find our way through this maze of things to do, we have to still flex our COVID-19 capacity, because we still have COVID as a feature in our hospitals. And we have to think about how to care safely for patients in that context, and to really think about their consent to that safe care in that environment. So what has the changing access to services done to people? What is the true impact of that? There are many proponents for telephone access to services, and for many individuals that's very convenient. But there's no doubt that for many patients, access to primary care services, for example, only via a phone or email has potentially disadvantaged them. Diagnosis isn't always easy over the telephone. People may be hard of hearing, or find it difficult to articulate their needs in such a way, or we may have missed diagnoses by doing that. And also for older people, there is a social aspect to this, of course, as well, in that many older people in this country certainly would see primary care as a way of interacting with people and getting themselves out of the house for their appointments and so on. So there's lots of hidden impacts on older people, I would suggest, around changing access to service, and particularly digitally excluded older people. So what might that impact have been? Well, of course, as a result of lockdown, we saw people really being quite fearful and shielding from COVID-19 infection. So people were quite isolated, with quite profound effects on their mental and physical health, potentially. So we saw a lot of reduced activity, loss of strength, and loneliness, of course, and depression and anxiety as a result of not being able to carry out normal activities. We also have seen potentially some suboptimal chronic disease management as well, for example, in diabetes. So all of these issues, of course, affect everybody in the population. I mean, I know for myself, I've felt my mood dip at times, and certainly put some weight on from being less active through the course of the pandemic. But for many of us, we are quite resilient, and we can return to pre-pandemic levels of mental and physical functioning very quickly. But this is not the case for many older people. And so the impact of all of this is almost certain to lead to poorer outcomes for that group of people, unless we do something urgent to address it. And of course, there's an economic factor to that as well, in terms of increased pressure on the healthcare system, increased acute healthcare utilisation. So to illustrate this, working with the Older People's Commissioner and my team of analysts, we tried to model the worst case scenario of what would happen if we saw a 5 and 10% increase in the rate of falls, for example, over the winter. And you can see from the graph that there are potential quite stark increases in hospital admissions and acute healthcare utilisation if we don't take those steps to reduce the effects of prolonged isolation and inactivity. So this is an urgent problem which we need to address. So what do older people need? Well, if we are to reverse the effects of the pandemic, many of the interventions that we need to take, I would argue, are actually outside of healthcare. So we need to be mobilising communities, creating community resilience, and access to local exercise programs, local social groups, and really trying to, from a social perspective, improve people's mental and physical health, as well as taking specific actions around their health and improving their chronic disease management and access to physical therapies to get people moving and building strength again where that's appropriate. So a value-based approach to this is quite useful because it shows where we can invest our resources or direct our resources and personnel towards improving outcomes for older people in that way. And it's really blind of a service. So it's not talking about hospital care or primary care, but it's really talking about needs and approaches, as you can see in this slide here, which describes the whole pathway of interventions in an integrated way for older people. So we need to figure out, how we provide more supportive treatment for people at home and reablement and rehabilitation, whilst also focusing on the prevention self-care aspects at the beginning of the pathway. And I think by mapping it out like this, we can start to understand where the gaps are in the healthcare service and make the case for measuring and improving the outcomes and directing the resources to improve those outcomes as we move through the next 12 months. It's really important that we do this, otherwise we are likely to see poorer outcomes for older people. So one of the key pillars of value-based healthcare, of course, is to use data and to triangulate data to help us with decision making, either around funding healthcare or around seeing where our outcomes are poorer and providing some insight into how we might improve them. So a useful concept for me is to think about this in terms of the needs of individuals, disutility of care, so what doesn't work and what is low value care, and also what are the really high value interventions that we need to focus on. And these three pictures attempt to illustrate each of those concepts of need, disutility, and value. So on the left here, we see the use of aggregated patient-reported outcomes in heart failure. Now, a patient-reported outcome is essentially a structured questionnaire which assesses the symptom burden of an individual on a given day. And in heart failure, symptoms of uncontrolled heart failure may include reporting swelling in the morning and reporting sleeping sitting up. So what we find when we ask our heart failure patients about these symptoms is that consistently about 2/3 of patients have none of these symptoms in the preceding 2 weeks. So they're very stable indeed. But also consistently about 15% have symptoms every single day in the preceding fortnight, and so are at risk of hospitalization every day and decompensation of their heart failure. So by using this data, I hope you can see that you can start to uncover need by looking at symptom burden in the community. And I would suggest that this is a really useful approach for older people as well, to start to understand what people's needs are so that we can address them, improve their outcomes, and reduce costs across healthcare systems. The middle one is around antibiotic prescribing and looking at how you can reduce unwarranted variation in something if you present data back to clinical teams. And broad spectrum antibiotic prescribing can drive antimicrobial resistance, of course, and Clostridium difficile, which had been traditionally thought of as a hospital-acquired infection, but also occurs in the community. And when you link the outcome with the intervention, which is in this case prescribing of broad spectrum antibiotics, you can start to get people to reduce that unwarranted variation and reduce that disutility of care. And then finally, on the right-hand side, this is about linking how we invest resource in the highest value way. And in a condition like chronic obstructive pulmonary disease, where there are sort of 3 or 4 main interventions: inhaler therapy, pulmonary rehabilitation, and smoking cessation and flu immunization. What value tells us in a condition-based approach like this is we need to really maximize the highest value intervention, which in this case will be smoking cessation and pulmonary rehabilitation. And what we frequently find is that the pyramid is inverted and we spend far more on inhaler therapy than either of the other things. And that's just the way the system behaves. So we can start to, when we look at this data, understand how we're directing our resources, understanding our outcomes, and beginning to rebalance the system. So how might a PROM support an individual over the course of an illness? So imagine if we have an older person with heart failure, the PROM, the patient reported outcome measure, tracks their level of physical functioning over time. And you'll see at the beginning that the physical functioning is low because they've just been diagnosed. And the idea is we want that slope to a plateau of stability to be as steep as possible. So in other words, we want to optimize their therapy as quickly as we possibly can for highest value, because that's the way we're going to get the best outcomes, going to reduce healthcare utilisation, and people are going to be feeling much better more quickly. And what we often see in healthcare systems is that upslope to a plateau of better functioning is much less steep and therefore much less good for patients. And then as the disease progresses, we can see how the PROM indicates that the person is entering a period of instability and worsening health. And this can be a really useful tool to initiate conversations around advanced care planning and palliative care with our patients. So the PROMs are not just useful in terms of shining a light on need or in assessing the effectiveness of an intervention, but also really helpful for people and their clinicians to track the trajectory of their illness and how they would wish to have their needs met in different ways over the course of that illness. And so I've talked about condition-based PROMs. Well, of course, that's no good necessarily in an older person who may have multiple morbidities and different sets of needs. So ICHOM, the International Consortium for Healthcare Outcomes Measurement, has defined an older person's standard set of suggested outcome measures. And you'll see from the wheel here that as well as disutility of care, such as polypharmacy and falls being measured, we're also looking at things such as autonomy and control, the time spent in hospital versus the time spent at home, and preferred place of care and preferred place of death. So lots of really important person-centered care measures in there. And this is actually increasingly being picked up around the world. So I was fortunate to run a session for the Australian Hospital Pricing Association a few months ago. And they have really started to embed this sort of data capture around older people into the way that they're delivering value for older people in their integrated healthcare system over in Australia. So it is being picked up internationally. So how might we finance for value, and how might we do the right things? Well, I believe that there are two important things, and particularly in relation to older people's care. The first is, can we incentivize excellence? So can we really incentivize the standardization of processes, for example, in that first phase of heart failure that I showed you earlier, and therefore avoid undertreatment and really sort of incentivize and reward the outcomes that matter to people in that way. But where over standardization might cause over treatment or not meet the needs and goals and preferences of an individual, we need to invest there in the time, the information for patients and their carers to support their shared decision making with their clinical team. And that's quite a cultural shift for patients and for clinicians alike. So that's the end of my section of the talk. Thank you very much for listening, and I'll hand back to Hamish.
Hamish, you're on mute.
Thank you. Thank you very much, Sally. That was great, just to reassure you that we heard every word, even though your moving image was not always moving. So I'm now going to ask Gérard Klop to speak to us. Gérard is the founder of a consultancy in the Netherlands called Vintura, and Gérard and colleagues recently published a really interesting report, and we'll post the details of the report in the chat for you in due course, which really was looking at how value-based healthcare can be used in practice. And there was a section that had a particular focus on the older person. And so it's with great pleasure that I ask Gérard now to speak to us. Thank you.
Thanks, Hamish. I will share my screen now. And maybe you can let me know that it works.
It works, yeah, that's great.
Okay. So thanks and welcome all to this webinar. I will build on what Sally just presented and elaborate further on value-based healthcare, whether it's the answer to post-pandemic situation, especially for elderly patients. But I will also address value-based healthcare in a broader sense. And I introduce also the concept of value-managed healthcare. The nice thing I just learned from him is that by coincidence today is the United Nations Day of Older People. So quite a nice coincidence that we cover this topic today. So let me start first with my source of inspiration also for this this webinar. I looked into the blog that Dr. Sally has written in July about the post-pandemic challenges, especially for elderly people, because apart from, let's say, their illness, they also experience mental problems in terms of loneliness, isolation, being disconnected from society, staying at their homes, but also therefore greater burden of the illness itself. And that is creating potentially a surge of ill health in older people, and with that the pressure on our healthcare systems. So Sally already has written in that blog, and she just explained it further in the beginning of this webinar, that we should be more careful in where we invest in terms of resources and healthcare budget. So we should better target our resources, and we need to collaborate. So that is basically the element of care integration, and I come to that in a minute. That's one of the dimensions of value-based healthcare. And the other one is around that we need to quantify and measure those needs and start to track patient-reported outcomes and make that visible. So that's about the outcomes measurement element of value-based healthcare. So all in all, to make things more visible so that we can better manage what matters to patients, and that we have a resource-efficient healthcare system and society. So let me quickly then explain what is care integration outcomes measurement from a value-based healthcare perspective. So you have all, or most of you have probably read the book of Michael Porter and Elizabeth Teisberg from Harvard University, Redefining Healthcare, which is the foundation for value-based healthcare. And actually we as Vintura, we looked at it and said, okay, what does this now encompass? So what is this all about? And basically we translated that into a growth path model for value-based healthcare. There's, let's say, the axis of care integration, and Porter talks about integrated practice units, where you really have a kind of shared responsibility for the final patient outcome. And there's the axis of outcomes definition and measurement and monitoring and steering towards optimal patient outcomes. So that's the other dimension that Porter is describing. But we have put those in a nice model and say, okay, these are the two main motions that you can have, along which you can change your healthcare delivery, basically. But, and that's also what Porter describes, there are some key enablers there, such as IT infrastructure and integral budgeting of care to make this all possible. And lastly, the fourth element here on the slide is, and Porter doesn't mention that, but the change management component is as important, because this has a huge effect on mindset and behavior. And Sally also alluded to that just a few minutes ago. And Porter describes basically value-based healthcare at large, which is at the top basically of the mountain. And we believe that also with in-between steps, you can already create value. So it's not necessary to go all the way to the end of both developments. Actually, we distinguish between two approaches that combined deliver you the value-based healthcare as Porter has meant it, where you have the axis of integration, which is more logistic and practical approach. So how do you cooperate between different care providers? How do you communicate? How do you integrate the patient care cycle? And there is the outcomes-based control, which is more medical scientific approach, because there you need to define what is relevant medical outcome, how does it correlate with relevant patient outcome, and which is more of a medical scientific approach for both movements along this value-based healthcare model. Again, the change management component kicks in. And as said, we believe that also interim steps can already deliver value for the patient. But combining both axes will provide you with the greatest benefits. But that being said, actually combining those two axes, that means both care integration and outcomes measurements, which is value-based healthcare at large, is not applicable everywhere. And I come to that in a minute, why that's not possible. I provide you some insights from our latest publication. And we were also inspired by 7 case studies that we used to tap into some key overarching lessons learned. So we learned that at value-based healthcare, as Porter has described it, is not one story fits all. And it largely depends on your patient population and the disease dynamics, and also the underlying care pathway. Although it's not, let's say, applicable at large everywhere, we still believe that applying a subset of value-based healthcare principles can also create value to the patient. So let me then outline to you what are the guiding principles for applying value-based healthcare. Where is it fit and where it is not? So first, to step into the outcomes measurement dimension. There it's very clear that if you think about it, that certain conditions have to be met to make outcomes-based control and even reimbursement, let's say, a sensible thing to do. First of all, the patient group has to be heterogeneous to a certain extent. Also, if the patient group is very comorbid, then it becomes more difficult to talk about one single patient outcome. And especially in elderly people, this is the case, of course. I come to that in a minute. The patient volume should be large enough to have statistically relevant outcomes. And also, if there are too many factors influencing the outcome and that are not in control of the care delivery system, it also can get quite complicated. Also, the outcomes have to contribute, being attributed to the interventions themselves, of course. And it's also not always the case that the results can be measured in an ambiguous way. So that's also something like, for example, mental well-being is a hard outcome to measure. And then, for example, survival results will only manifest themselves in the long term. Then it's also hard to control your care cycle today if the patient relevant outcome is only manifesting itself in 3 to 5 years, for example. And also, if there's a high degree of innovation in diagnostics and or treatment, then the outcome, let's say the targeted best outcome that you are using as a benchmark is constantly changing. So that makes it also complicated to talk about outcome-based measurement and control. So these are key considerations to take into account when you talk about the outcomes measurement axis of value-based healthcare. Then secondly, and here it becomes a bit theoretical, but it's a very important slide. It's the integration of care is also something that the way Porter meant it, he talks about an integrated practice unit. And actually this is only the case if you talk about a homogeneous patient group in a multidisciplinary setting. Then you talk about the line model, you see it on the left, where the care pathway is like, you can clearly define it, it's standardized, and your patient group is relatively homogeneous. If it's a monodisciplinary homogeneous patient group treatment, then it's a standard intervention. Then we talk about the routine model. There you don't need to integrate care, but you can measure outcomes, of course. The agile model is in the case where we are monodisciplinary and heterogeneous. That is what is happening at the GP, right? Where he is just looking at the individual patients and does tailor-made intervention when needed, or refers to more specialized care in the second or third line. And then lastly, on the top is the job shop model. It's the care network. And this is a very relevant one when we talk about elderly patients. I'll come to that in a minute. And then the hub and spoke model, which is a better version of the job shop model. So these are, let's say, 4 care delivery models. And I just quickly take a smaller deep dive on the suitability for value-based healthcare. So on the left, you see the line model, a multidisciplinary care for a homogeneous patient group. For example, hip transplantation, and also in cardiovascular diseases, you see a lot of application there. High suitability for value-based healthcare. You can integrate all the interventions into an integrated virtual practice unit, and you can also measure outcomes in a consistent way. Then in the middle, you see the routine model, which is monodisciplinary. Well, integration doesn't play a role there. Think about physiotherapy after a specific injury, but outcomes measurement is very relevant there. And then the job shop model, which is a multidisciplinary care setting for a heterogeneous patient group. For example, Parkinson's disease, and also elderly patients, because of their comorbidities, they are in this more organic, let's say, way of delivering care, and they are basically all following different pathways. This has a very low suitability for value-based healthcare. I come to that in a minute, and here we should rather coordinate instead of integrate care, because you cannot talk about a single care pathway. And then the agile model, like I said, the GP situation, for example, monodisciplinary, very heterogeneous, not very useful to think about value-based healthcare, limited possibility for outcomes measurement, and no need for integration unless you incorporate the GP in a specific disease focused cycle. And then you need to train the GP to become part of early interventions or secondary prevention and so on. But as such, standalone, the GP is not very fit for value-based healthcare. So then talking about the job shop model, I already said the hub and spoke model is a better version of that, and that's where you start to add an additional element, the coordination point. And there's a very nice example of that point for Parkinson. It's a Dutch regional initiative where they have really great outcome in central coordination of care, and also coordination of outcomes that matters to patient based on the patient dialogue and transparency. And this is what I call value managed healthcare. So it's not value based healthcare in the sense that you integrate care and you start to really measure rigid care outcomes. You can measure certain outcomes, of course. I come to that also in a minute. But it's not the value-based healthcare where you have a single track care cycle with very specific medical and patient-related outcomes. So talking about outcomes here, the main question is, should we measure outcomes to control the care? So looking back and measure, or should we define them in a dialogue with the patient to coordinate care as a leading indicator and say what is relevant for you, patient, and we make sure that we coordinate the care cycle based on the patient's specific context and needs? Or should we do both? So both coordinate the care based on the dialogue with the patient and measure afterwards what came out of it. But we should realize that measuring health outcomes in elderly population is hard to measure and interpret in a consistent manner, because of all the comorbidities and the different interventions that are taking place. So bring these insights together, care for the elderly, value managed healthcare instead of value-based healthcare. So the elderly population is comorbid and therefore very heterogeneous. You see in the graph that the older the patient gets, the more multimorbidities you will have. So there is no single unambiguous care process, first of all, and secondly, there is no standardized outcome. So it is, you cannot say that what is true for patient A is true for patient B. And if you look at the ICSM standard set for older persons, you see it's a rather broad set of holistic outcomes that you cannot link to one specific medical intervention, right? It's about ability to control your own situation, days in the hospital, general mental well-being, and so on. But that is influenced by different care providers, and also if the patient has multiple diseases, multiple care pathways. So this is a very hard nut to crack. And for me, the first thing to do is not so much start to measure, although it makes sense to do it on individual diseases, but there it could make sense to start measure outcomes. But in general, it's much better to think about the coordination of care first, and then later on start to organize outcomes measurement. Because if you look at the job shop model at the moment, we don't have real coordination. Nobody's really owning, let's say, the final results. So you see a lot of patients falling between the cracks. And this lack of coordination leads to undertreatment, overtreatment, miscommunication, and errors. So not a very efficient system. And we cannot no longer afford that, especially with the growing elderly population, combined with the COVID impact, which creates an additional layer of complexity. So what I believe in, and based also on the case studies that we did, is that we should go for value-managed healthcare around one medical condition. Of course, if this is a hip replacement, then you can organize it in a line setup and go for the full value-based healthcare solution at large. But if it's a more organic disease like Parkinson with multiple elements, then you rather organize it in a value-managed healthcare setup with a central coordination point. And then if you combine it all together, you can start coordinating across different diseases that are then organized based on disease specifics, either in a line setup or value-managed healthcare coordination point setup. So then you have an overarching value-managed healthcare point at regional or national level. And especially in elderly care, this can create significant value to avoid over-treatment, miscommunication, people feeling left out. The question now is who should take this role, and that's something for further discussion. We elaborate on that in the book that we have written. So coming to that in a minute, but we believe that, let's say, regional national coordination will help to make the invisible visible, and to proper coordination of care steer towards relevant patient and agreed outcomes. And thereafter, I think it makes sense to start building up further insights and measure outcomes to further improve this coordination function. Well, these were some highlights from our report. If you want to have the full report, you can download it from our website, and I think we also will share now the direct link in the chat. And now I give it back to Amish for Q&A and discussion. You're on mute, Amish.
Hamish, you're still on mute.
Apologies. So yes, thank you, Gerard. And we have posted it in the chat, and it's a quite a long report, but it's a very good read, and I would strongly recommend it to people. So we have a bit of time now for a Q&A, and we've got some questions. Thank you for posting them in the Q&A. There's one that's got into the chat. I'll try and pick that up if we have a second. And just to remind people again, if they particularly like a question that someone else has posted, if you click on the hand, the like, it'll score it and bring it nearer to the top of the questions. So a question first, if I may, from Maria Bell. how is the NHS working with partners across the wider pathway, so that's social care and third sector and community services, to manage demand failure, which is impacting on admissions and delayed discharges and therefore by definition contributing to poor value? Sally, would you like to have a go at that?
Yes, of course, Hamish. Thank you. Great question, Maria. So I think there's been, the health boards have been doing a lot of this type of work in recent years, but we need to do more, clearly. And this is the conversation that I've been having recently with the Older People's Commissioner about how we commission third sector organisations in particular to build that community resilience and create those integrated non-medical interventions that older people will clearly need to support their mental and physical rehabilitation as we move out of the pandemic. So it's my belief that we need to really strengthen that partnership and increase investment into those organisations to support that.
Thanks very much, Sally. I'm going to move on, if I may, Gérard, just because we've got quite a few questions, and I'm keen to get through a number of them. Perhaps we could just talk. There's a question that's got into the chat. If people could use the Q&A, that's for a bear of simple brain. It's easier for me. But Gérard, a question for you really. Do you think this approach is really about a kind of medium to longer term approach rather than short term, because of the kind of cultural changes that are required to adopt this way of thinking? That's from Vanessa.
Sorry, I was on mute. This is a very good question. Actually, I think this is the nice thing about this. This is both, actually. You can rather quickly implement this, for example, around a specific disease without a lot of, let's say, upfront investment in terms of IT infrastructure that can follow later on, but already putting a coordination point and where you also reach out to patients, you can implement rather quickly. But for me, it's also the longer term, midterm solution, because I strongly believe that there will be an increasing elderly population, of course, there will be more chronic diseases. So the pluriformity of patients and also the number of people needed in healthcare, we need to be very efficient with our resources. So I strongly believe that this is also a long-term solution, but it can be implemented rather quickly in a, let's say, very hands-on way, and then built on that by implementing further infrastructure, IT, outcomes measurement, and by bringing that then all together at the central point, you can even start putting artificial intelligence on top of that to look for common correlations and so on. But that's then really future and forward-looking.
Thank you. And Sally, what's your view about that? Do you think, given our history in Wales, we're still looking to the medium long term, or are we closer to some wins?
Well, first of all, I agree with Gérard. I think that there are some shorter term gains to be made. But I do think Vanessa has hit upon a very important point. This is a huge cultural shift for everybody. And when we're talking about large scale transformational change to meet the evolving needs of our population over the next 10, 20, 30 years. And some parts of the system will simply not be ready. So our approach in Wales, as you know, Hamish, has been to really support that cultural shift over the last 5 or 6 years. And we've achieved quite a lot of that, I think. Still a long way to go. And the cultural support doesn't stop ever. But I do think we're well placed to take a value-based look at the system and make some quick interventions, particularly around this issue of older people as we move out of the pandemic, because it is really quite a pressing issue.
Thanks very much indeed. Right, so I'm going to move on because we've got lots of questions, which is great. There's a question from Simon Rogers, and actually there was another question that came in advance of the webinar, which to some extent is the same subject, which is the challenge around the money. And Simon Rogers is asking, taking your COPD example, Sally, that it's great to be able to disinvest in something and reinvest it in a higher value part of the pathway. But how do you do that at the same time when you've still got to keep running the low value part until you've got the high value part in place? And there was a separate question from Mike Bond, which came in, which was a similar question of how do we make the money work to support this sort of approach to value-based healthcare?
Thanks, Hamish. Shall I have a go at that?
Do.
Well, so where I do really agree with Gérard is that the implementation and application of value-based healthcare principles is highly contextual and depends on the patient group that you're looking at and also the healthcare system that you're working in. So in Wales, we will never be paying for outcomes because, like Gérard, I also agree it's extremely difficult and complicated to attribute outcomes to single interventions, for example. So, but there are many ways to deliver value across an integrated care pathway. And one of those ways is to reduce low value activity, to reduce disutility of care. And the other, of course, is to improve outcomes and increase our investment in high value interventions. And that's what the COPD example is meant to illustrate. So we did this 7 or 8 years ago in a health board not far from here. And of course, it presupposes that you are over-prescribing or spending too much on inhalers that are not improving patients' outcomes. So it's not about disinvesting in inhalers, it's about prudent prescribing. And if you make some savings from that better prudence in prescribing, my argument was then and still is that should not just go to the bottom line of an organization, but a portion of that could and should be reinvested in another part of the pathway that is going to improve patient outcomes. So in that case, it was about prudent prescribing, generating savings, and making the case for investment in pulmonary rehabilitation. Now, of course, the next question will be, well, it's not as simple as that, is it? Because you can't shift resource when there might be still a deficit in the budget, or you want to invest in a different department and it's somebody else that's made the savings. So there does need to be, certainly in the Welsh context, in my view, a toolkit, a finance toolkit, and I've talked at length to finance colleagues about this, about how we increase high value interventions. You know, do we need a corporate function around that so that, as Simon says, you can invest and make sure that you're investing in those high value interventions, let's say for a particular condition or for older people, so that it isn't just about trying to always recycle savings, because that on its own, as we know, will not be sufficient and takes too long.
Thank you very much indeed.
May I add here?
Please
or
do. Yeah, please do.
So I think in order to make these decisions, you need to have this overview, right? And at the moment we don't see what is happening, and I think there are in a lot of areas some very big quick wins if you look at it, and you can save a lot of money. And I think this money should not then be let's say reaped off, or how you say that, being taken out of the system, but you need to use it to innovate again somewhere else, like Sally said. And to give you an example, in the Parkinson disease, where there are, I think, 30 different functions from primary, secondary, mental care involved, and every patient is following a different route. There were patients falling between the cracks, and there was a lady, for example, staying in the hospital for years in a row. Then this was made transparent because they put this coordination on top of that, and it was driven by a professor. It was now his personal drive to improve the care for this disease, right? And that's what you need, this ownership and change in mindset. And this lady, with one injection, she was able, really a few hours later, to sing a song on her birthday. That was a nice coincidence. But you see that she was occupying a hospital bed, and with just a pharmaceutical intervention, she could have a normal life again. So you can have huge savings, but for that you need to have overview, and indeed you need to have integral budgeting. Otherwise, it will not stimulate innovation.
Thanks very much indeed, both of you. There is a question about NHS backlog and increased waiting lists. If people forgive me, I'm not going to take that, just because I'm quite keen we focus quite narrowly on this question of older people's care and how we organise care. The answer is there are lots of ways. Happy to pick that up afterwards. A question from Sarah Louise Beasley to both of you, I think, is there a role for partnerships for value with the pharmaceutical industry and indeed the medtech industry in this area of care? And if so, are you aware of any examples, or do you have any thoughts about that? Gérard, do you want to start?
I can take that one. Actually, we do a lot of joint assignments. We as Vintura, we have a life science and healthcare practice. And actually, these two worlds are now coming together, where we basically optimize care around the care pathway, and it's a win-win-win, because pharma is quite interested to see where it's relevant to treat and not relevant to treat, and to articulate further, articulate and augment their value claim that they make. So they're very much interested in, let's say, optimizing care and measuring outcomes, as well as the hospitals and the payers. So we are building consortia around, and this is then around specific diseases where we take an integral view at the care cycle. And we have examples in cardiovascular, in CNS, a lot of examples.
Thank you. And perhaps just for the sake of time, just to say that in the Value-Based Healthcare Academy, we focus very much on the opportunities to work with the life science sector. So really happy to have a chat outside about that as well, if anyone would like. We're nearly out of time, so just a very quick question. And I'm going to take Jo Ferris's question, if you may, which is really, she's saying, how do we grasp the early successes and communicate them effectively to kind of support and encourage change? Do you think that's important? And if so, how do we do it? Gérard, quickly, and then Sally.
Yeah, so that's a very important one indeed. And I think this needs to be on an agenda somewhere, preferably on the national agenda, to make the change and to have a consistent communication about successes. I think that's key for change. What I see happening in the Netherlands, it first started at the bottom, where medical professionals felt more from the personal drive that they wanted the change. And started communicating, but they were not able to create the critical mass. At the moment, there is a national program going on where there's a whole value-based healthcare training in the Netherlands for healthcare professionals and providers. We are supporting them on that to raise this awareness, but I think you need to have this national ambition and drive, and it should land somewhere. I think in the Netherlands is with the health insurers, they should own this to a certain extent, to show that improvements are being made and communicate about this. And I think in the UK and in Wales, it's probably another party, maybe NHS, or I don't know exactly what would be the right person to lead this change, basically. But it has to land somewhere on the central level. Excellent.
Sally, 30 seconds.
Well, fortunately, I think that's my job that Gérard's just described. So the National Value in Health programme in Wales is centred around 6 pillars of work to support the delivery of value-based healthcare across Wales. And one of those is critically important, which is communication, education and engagement. And that covers formal education, such as we see at the Intensive Learning Academy, led by Hamish, but also communication and engagement, website, conferencing, webinars, community of practice. All of these activities are necessary to continue to build momentum and cultural change towards value-based healthcare.
Thank you very much. And a thank you to both of you. I'm going to just go, if I could go to the last slide, Nicole. Just really, it's been a fantastic discussion. So thank you so much. We could have done with much more time because there's still questions to answer, but that's always a good sign, I think. Really just to leave you with this, as I said at the beginning, this is the first of the series. There'll be more. If you want to be told about them in the future, we'll try and do that, but please do get in contact if you'd like to. In the Academy, which is built on education, research and consultancy, clearly this is part of our education area, but we're offering an MSc a doctorate of business administration, executive education short courses. We've got an online learning platform coming in January, and this masterclass series as well. Lots of information on our website. Thank you so much again to both of you for a really thought-provoking hour, and I hope everyone has a great weekend. Thank you so much.
Thank you.